In 2017, a major paper in JAMA concluded that radiofrequency denervation for chronic low back pain didn't beat an exercise program. 6 published responses pushed back hard, calling out specific problems with how the study was done. Both sides have a point. Welcome to the educational channel of Dr. Ryan Kuda, a board-certified interventional pain physician serving the Chicago area. On this channel, we break down the research that shapes how pain medicine is actually practiced. Today, we're presenting the MINT trials. Radiofrequency denervation, also called radiofrequency ablation, or RFA, is a procedure that uses heat to interrupt pain signals from small nerves supplying the facet joints or sacroiliac joints in the spine. It's a commonly performed interventional pain procedure for chronic low back pain. The MINT trials asked a foundational question: how much does it actually help? The clinical question, in plain English: in patients with chronic low back pain coming from the facet joints, sacroiliac joints, or some combination of pain sources, does adding radiofrequency denervation to a 3-month exercise program improve pain more than the exercise program alone? The PICO: adults with chronic low back pain and a positive diagnostic nerve block. RFD plus exercise versus exercise alone. Pain intensity at 3 months. This wasn't one trial. It was 3 pragmatic randomized trials bundled into one publication. Trial 1, facet joint pain, 251 participants. Trial 2, sacroiliac joint pain, 228 participants. Trial 3, a combination of facet, sacroiliac, and intervertebral disc sources, 202 participants. Total, 681 patients across 16 multidisciplinary pain clinics in the Netherlands, enrolled between 2013 and 2014. All participants got a 3-month standardized exercise program with psychological support if needed. The intervention arm also got radiofrequency denervation, up to 3 procedures over the course of the study. The primary endpoint was pain intensity on a 0 to 10 numeric rating scale at 3 months. The pre-specified minimal clinically important difference was 2 or more points. Final follow-up went to 12 months. There's a critical methodology detail worth flagging now, because the entire controversy hinges on it. Patients qualified for the trial based on a single diagnostic nerve block. In interventional pain practice, multiple confirmatory blocks have been recommended before proceeding to ablation. That difference is what the published critiques focus on. The headline result: across all 3 trials, radiofrequency denervation did not produce a clinically meaningful improvement in pain at 3 months. For the facet joint trial, the mean difference between groups was minus 0.18 points on the 0 to 10 pain scale. The 95% confidence interval ran from minus 0.76 to plus 0.40, straddling 0, not statistically significant. For the sacroiliac joint trial, the mean difference was minus 0.71 points, 95% confidence interval minus 1.35 to minus 0.06. Statistically significant in favor of RFD, but well below the pre-specified 2-point clinical threshold. For the combination trial, the mean difference was minus 0.99 points, 95% confidence interval minus 1.73 to minus 0.25. Again, statistically significant, again below the clinical threshold. 88% of patients completed the 3-month follow-up, 77% the 12-month follow-up. The authors concluded the findings did not support routine use of RFD for these conditions. Within 6 months of publication, multiple responses were submitted to JAMA, Pain Practice, Neuromodulation, and Regional Anesthesia and Pain Medicine. A 2020 commentary titled, "Let Us Stick to the Facts," summarizes the methodology concerns. 3 main points. First, the diagnostic block protocol. MINT used a single block. Multiple confirmatory blocks have been recommended in interventional pain practice, and some commentators raised concern that a single block protocol may include patients whose pain isn't actually originating from the facet or sacroiliac joints, which could dilute any treatment effect. Second, technical considerations. As a pragmatic trial, the procedural technique varied across 16 clinics. Some commentators raised questions about whether ablations consistently followed common technique standards. Third, what was actually tested? Some commentators suggested MINT measured real-world performance under broader patient selection rather than efficacy under more restrictive selection. Those can be different research questions. So what does this mean in practice? First, MINT is a real result. Multi-center randomized trial, 681 patients. Formal statistical analysis, primary outcome below the clinical threshold. The findings are technically valid. Anyone arguing that RFD has overwhelming evidence in its favor needs to engage with this paper. Second, MINT also has methodology concerns that have been raised in the published literature. Single diagnostic block, real-world technique variation, pragmatic design rather than efficacy under more restrictive selection. The published critiques come from across the interventional pain medicine community and raise questions that have not been fully resolved. Third, the most accurate read is probably this. A definitive efficacy trial of RFD under more restrictive patient selection, using multiple confirmatory blocks, has not been published. MINT showed that RFD, as practiced in a heterogeneous real-world Dutch population selected with single blocks, didn't beat exercise. That is not the same statement as RFA doesn't work for back pain. Fourth, for a patient considering RFD today, it's reasonable to ask the proceduralist about the diagnostic workup. The published critiques suggest the choice of diagnostic block protocol may influence the likelihood of a meaningful response. Bottom line, the MINT trials found radiofrequency denervation did not produce a clinically important improvement in chronic low back pain across 3 randomized trials. Multiple methodology critiques were published, focused on patient selection by single rather than multiple diagnostic blocks. The trial is technically valid, and the critiques are substantive. A definitive efficacy trial of RFD under more restrictive patient selection has not yet been published. A reminder before we wrap. This is educational content, not medical advice. Talk to your own doctor about your specific situation. If you found this useful, hit subscribe. Next week, we're breaking down the Sunburst study, the randomized trial of the burst waveform for spinal cord